and welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This current series focuses on demystifying the Medical Council standards, and today's podcast is all about providing care to yourself and those close to you. What's so wrong with that? My name is Dr. Sam King and I'm a medico-legal consultant with Medical Protection, and I'm joined today by Mr. Adam Holloway, who's a partner at Watt & Carney, our panel law firm. Glad to have you back with us for this podcast, Adam.
Thanks, Sam. Always good to be here.
And I have with me as well Dr. Lucy Gibbard, who is a medico-legal consultant and GP. Hi, Lucy.
Hi, Sam.
You know, as doctors, we're never fully off the job, in that when the need arises, we have a professional and ethical responsibility to step in as a good Samaritan. I'm sure many of us have helped out a patient on a flight or on the street when they've come to grief. So when a family member or friend asks us for help, we often want to provide it. In fact, there's often a pressure to prescribe it. Our family and friends often trust us more than they trust other clinicians. And in some cultures, there is a strong expectation that we will help. And I recall speaking to an older GP relative of mine, and every time he went to a family wedding, he took his prescription pad in his back pocket. That was the culture and the expectation in that day. This was obviously quite a long time ago. In years past, the Medical Council were not averse to treating family and friends. But over time, this has significantly changed to the point where we have seen a significant rise in the number of members having to respond to Medical Council complaints about this issue. And one such case is the case of Dr. Wainwright. And now obviously I've changed a lot of details in this particular case, but Dr. Wainwright is a 60-year-old rural GP. And he's living in a town with 2 other medical centres. Each GP is rostered for after-hours care, including weekends, and when his children were young, he would treat them after hours if the need arose, and often this was when he was on call, but not always. Over the years, his children grew up and obviously left home, and Dr. Wainwright moved to Hamilton with his wife and took up a job at a busy medical centre. One day, his teenaged granddaughter, Tina, made an appointment to see him on a Saturday morning. She'd been out on a hike and fell heavily, lacerating her calf, and he treated her wounds and signed an ACC form and thought no more of it. 2 weeks later, ACC contacted Dr. Wainwright and they asked him about the ACC certificate and whether he had treated a family member, given they both had the same surname. Dr. Wainwright admitted that he had. ACC then set out their expectations in their position statement, which aligns with the Medical Council, the Nursing Council and the Physio Board. So Lucy, are you aware of what the ACC position statement says?
Actually, Sam, yes, I am. I've got it here right in front of me, so I will share that with all of you. So look, the ACC statement, decision statement says that treating family members can blur professional boundaries, which results in poor clinical decision-making and encourages excessive or unnecessary treatment. We consider family to encompass whānau, family members and those close to you. And while we recognise there are exceptional circumstances where treatment of family may be unavoidable, we consider it generally inappropriate and unethical for treatment providers to claim payment for treating family. Exceptional circumstances for treatment of family members would include an acute treatment provided in an emergency where, in your reasonable judgment, the need for treatment is urgent given the likely clinical effect on the person of a delay in treatment, or situations in rural areas where there's no other appropriately qualified treatment provider available to give the required treatment. If you believe that these circumstances apply and you choose to treat a family member, you should document that you considered any impact on good clinical reasoning and the conflict of interest or the power imbalance concerns. It's your responsibility as a treatment provider to ensure that the care you provide meets the clinical, professional and ethical standards of your profession. We're unable to fund treatment provided in a non-emergency and treatment that would ordinarily be provided by a family member. We may also notify the relevant regulatory authority if we consider there is a potential risk of harm under the Health Practitioners Competence Assurance Act 2003. So that's the little hook at the end, that actually if you do treat family members and put an ACC claim in, ACC may well report that doctor to the Medical Council. And interestingly, they're saying they're not going to fund treatment that would ordinarily be provided by a family member. So if you're changing a dressing and it would be a dressing that your mum would normally change and it's your child, obviously you can't charge ACC for that. And, you know, I think in general what they're saying is you've just got to be really careful in the exceptional circumstances in an emergency. You obviously would provide care if there's nobody else available, but actually you need to be very careful about that, and you've got to be considering whether or not you should charge ACC for that.
So if Dr. Wainwright was on call working in rural New Zealand, would he have been okay?
That's a hard question. And would it have been okay, you know, if he hadn't charged ACC and he had said, because I think he was on call, wasn't he? I think he was on call, and it was a laceration, and there may not have been any other doctor available, so he might have met the exceptional circumstances. So, yeah, possibly he would have been. It was in a clinical context. She booked an appointment and saw him in a clinic, and I assume there were clinical notes, and, you know, everything was done to a standard as with any other patient. So from the Medical Council's point of view, I think we'd have quite a strong argument that actually that was appropriate because there was no one else available to provide that urgent care. What do you think, Adam?
Yeah, I think you're right. So the Medical Council would expect you to turn your mind as to whether there is another option available here. So in the scenario you painted, Sam, I remember back in the doctor's hometown, I think it was one of 3 medical centres, you would be encouraging patients to present to a doctor at another medical centre if that was an option. But if they're on call and it's the only doctor on call, then I think you would go ahead and treat. In a place like Hamilton, it becomes a little harder to make that argument, although that one instance of care on its own, even if it's brought to the Medical Council's attention, is unlikely to get you in any serious trouble. It's really how the council typically responds to being alerted to things like that, where doctors often run up against an iceberg.
We have had some contact from members who've been treated by a colleague or they've treated themselves, and often what they say is, you know, currently under the pressured system that we work in, you go to the local A&M and it's a 4 or 6 hour wait, or you know, the local ED similarly. So it's expedient to treat yourself or to treat your family member, isn't it? How do you think the council would respond in that sort of situation?
Yeah, not with a great deal of sympathy. I've never seen an argument of expediency really persuade the council, and that they will look to their statement and apply that reasonably strictly. And because there has been such a shift in attitude towards providing care, in particular prescribing for yourself and others, it just comes up again and again and again as being one of the most common things we deal with. And the Medical Council is keen to drive home a message. So for Dr. Wainwright, if the ACC alerts the Medical Council to this example of providing acute care to a granddaughter, it would be very typical for the council to then, on its own motion, go to the Ministry of Health and ask for Dr. Wainwright's prescribing data to see if he has prescribed to anyone else who shares his family name over the last 18 months, 2 years, or to anyone else who has the same residential address. And often what looks like an isolated case that you can think, well, look, we can explain that, it's probably not going to be an issue, will become a bigger problem once the council presents you with a spreadsheet to lay out the various prescribing for family and to the doctor, him or herself, that's occurred over the last usually 2-year period.
It's I think for a lot of doctors who do prescribe for friends and family, they might not actually be aware even how much they've been doing this. It just is one of those things, it's been the occasional. But when you actually see the list of medications that we see that come through for our members, it can be very extensive, can't it?
Yeah, it certainly can. And I can absolutely understand that perception, because particularly if you're working in primary care, prescribing is at the heart of what you'll do. Commonly in many or most consultations, your overall list of prescribing might be enormous. But of course, they're only going to focus on the ones that are a problem. And you look back over a time period like 2 years and they take into account the repeat dispensings, it can quickly look like a problem from the medical council's perspective. And it's also worth taking note that not all medicines are the same. So what the relevant council statement says is that you, in most situations, there's a intention that you don't provide care for yourself or your family members, but the statement says there are some situations where you must not provide care to yourself, and that includes prescribing or administering medication with a risk of addiction or misuse. So you can imagine that might be some analgesics. They would probably put Zopiclone in that list. You might see something as being relatively low level, particularly if you're doing a repeat from medicine that's been started by a specialist, but it still falls within that must not category. Another must not is that you must not prescribe psychotropic medication or controlled drugs to yourself or family members. So that would include doing something like a repeat of an SSRI.
Yeah, that's really useful, Adam. And look, when we're thinking about that must not list on the council statement, there are some other things on that must not list which I think is useful to think about. So you mustn't ever issue a medical certificate for family and friends, or perform any invasive procedure. So that would include just doing a punch biopsy or something like that. You can't conduct a medical assessment for a third party, or conduct psychotherapy, or issue repeat prescriptions if you're unable to review whether that prescription is suitable. And that's all on the council's must not list. So those are the things that the council particularly take exception to. So yeah, as well as those other two issues that Adam picked up, it's worth remembering those.
Thanks for that, Lucy and Adam. In terms of family members, let's just say it's someone who's distantly related to you, and they might be your second cousin or your daughter's partner's mother or something like that. Would that be captured in this medical council statement about treating someone who's related to you?
Well, it's probably worth just reading out the definition that the Medical Council has included in its statement. So they define both family member and those who are close to you. Family member is defined as an individual with whom you have both a familial connection and a personal or close relationship, such that the relationship could reasonably be expected to affect your professional and objective judgment. Family member includes, but is not limited to, your spouse, partner, parent, child, sibling, members of your extended family or whānau, or your spouse or partner's extended family or whānau. So it's a very wide group that could potentially fall into that category, but in a large extended family, there may be people there who you don't know that well, that you would be able to treat. But if you're taking a careful or a risk-adverse approach, I think you should always be asking yourself the question, look, I'm related to this person, is this a wise idea? And that concept of whether or not your professional or objective judgment will be affected, I think from my experience, the way the council will look at that is probably not take your word for it as a doctor. They're probably not interested in whether you feel like you were compromised, but really taking an objective view as an outsider. whether the council feels like you were really able to make a completely, take a neutral approach to that patient. Moving on to that definition of those close to you, they say that this will attach to any other individuals you have a personal or close relationship with, whether familial or not, where the relationship is of such a nature that it could reasonably be expected to affect your professional and objective judgment. And the council recognises that those close to you will vary for each doctor. And the sorts of cases that we see that where that definition is engaged will often perhaps be younger doctors who are in flat shares, living with other people, perhaps colleagues who they've known through medical school that they're prescribing for, or they've got a boyfriend or a girlfriend who they prescribe for. So those people may not formally be part of your family, but I would say certainly the council would see that as meeting that test of being close to you. If you're living with someone, you're interacting with them every day, there's always that chance that you'll be more inclined to prescribe a medicine that they are seeking, or prescribe in a context where you're not going to be keeping good notes, or that you're not doing those normal things like blood pressure examination, recording vitals that perhaps you would do if you were seeing that person in a consult.
And I think that's often the real key to it, because we often get calls from doctors saying, look, I live in a small area. Of course, my patient is my next door neighbour, because that's the way life is here. Is that someone close to me? And we often say it's not just about the relationship, it's also about the context of the clinical encounter, because if you have a lady who lives 2 doors down and you know her, from being a neighbour, but she comes to see you in a booked appointment and has a UTI, and you dipstick her urine, you write good notes, and you provide her a script for trimethoprim or whatever you're going to give, nitrofurantoin these days, that would be looked at differently with exactly the same person if you actually just handed her a script over the fence when she said, I think I've got a UTI, can I have a script? So it's not necessarily just the closeness of the relationship, it's also in what context have you seen them, which if you're much safer seeing those people in a clinical context, even if there is some vague close to you kind of relationship.
Yeah, absolutely. And the sorts of cases that get investigated from a disciplinary perspective, they won't always go to discipline and be the subject of a charge, but commonly they will be investigated. And it's quite a mitigating factor if, despite the person falling within that category of family member or someone close to you, you have got notes. You have done what would normally be expected. And this is quite a common issue. You have, for example, kept their usual GP informed about what you've prescribed, and that's such a common issue to be raised by the medical council as a source of risk that arises from treating people informally, apart from the usual medical system that we rely on to keep everyone up to date with what's happening for a patient.
I think, just recently I've had members call because the pharmacist has taken exception to a prescription provided by a colleague to someone who works in the same place of employment as you. And often these medications for things that you can in fact buy over the counter, like omeprazole or Panadol or non-steroidal, something very simple like that. And it just, obviously it's cheaper if we take a prescription than buying them over the counter. But the pharmacists have taken exception and notified the medical council over these matters. Do you think that working with a colleague would be captured in the close to you definition that the medical council have?
I think it's the sort of scenario that we could have a good argument about with the council, but far better not to find yourself in that position. If you're in a town where you do have a choice of medical practice, I think it would always be prudent to be enrolled with a GP in a practice different from the one that you're working at. That getting some distance from that business relationship and those potentially quite intense personal relationships that you can have with colleagues that might impact your willingness to go and have, for example, an intimate examination. And if you are enrolled with a GP somewhere else, then that should be the person who you turn to for your scripts, even if it's over-the-counter analgesic that you would rather have on prescription. Go ask your GP. Don't ask a colleague, because it puts you and them in a tricky situation and creates that opportunity for a report. And even something that we can navigate through and achieve an outcome where nothing bad happens to you, we are still talking about a 4 to 6 month process where you're going to have to be spending your precious time talking to lawyers and being anxious about the medical counsel rather than focusing on your work and family. So that would be my slightly stern advice.
Spoken like a true lawyer. No, I think that's good, Adam. So if we think about the situation where you've got a family member, they need an ultrasound, and you think, actually, I think it's expedient, I'll just order that for you, and then we'll see what it finds, and then we can go from there. Or then, if it shows something abnormal, then you can go and get treatment. Would that be considered treating somebody by the medical counsel?
Yes, it would. And the statement that the council will apply to these scenarios defines what providing care is quite broadly. It includes anything that's done for a diagnostic, preventative, palliative, cosmetic, therapeutic, or other health-related purpose, and it goes on. It's a very comprehensive definition. And I think what you'll face if you try and excuse that sort of conduct with the council is, again, not only are you making choices that may not be objective, but there are issues around the cost-effective use of the public health service, whether or not that's an ultrasound that you would have ordered for another patient. It may well be, but suddenly you're confronted with that question because you've chosen to do that instead of say, look, I think you probably need an ultrasound. Go and book some time with your GP and tell them that.
It can be really tricky because I think family members often put pressure on clinicians. And I know I've definitely had cases where the doctor has felt quite pressurised by their family member to provide care. And it was causing issues within the family when she refused. So, you're kind of damned if you do and damned if you don't. But I kind of think that the medical counsel is probably the greater of the two evils. Best avoided.
I think sometimes it's actually a legitimate excuse to say, look, I'd really like to do this for you, but I'm very likely to get into difficulty with the medical counsel, and for that reason, I can't. And so you make the medical counsel the bad person in the room, so to speak. Because I understand that kind of pressure. I've certainly felt that in the past in my family, my wider family. But it's actually really helpful for me to be able to say,
I can't.
There's a big stick if I do this. Mm.
And I think we also find there's a lot of international medical graduates who've come to New Zealand who don't quite realise how different things are here than in the rest of the world. There are definitely a lot of areas of the world where doctors do prescribe for themselves and their family, and that it's considered normal. So, I think it's a particular issue for international medical graduates, in fact.
So, Sam, just perhaps before we move on to think about the situations where it is okay to treat those close to us, to round out the example that you went through of Dr. Wainwright, I said earlier that we can expect the council to, when they become aware of one example of treating someone who's close to you, they will go and look to see what you've prescribed in the past. And I understand that in this scenario, that is indeed what happened. They obtained from the Ministry of Health the prescribing for the past 12 months, for Dr. Wainwright and found that he had prescribed on numerous occasions for family members, most with antibiotics and pain relief, but there was one SSRI that he had prescribed on a semi-regular basis for one of his children. When we get confronted with those sort of facts, you can expect that the council will refer that doctor to a professional conduct committee or a PCC to both look into what's happened, but also give an opportunity for the doctor to appear before the committee and provide an explanation and front up to the conduct. For Dr. Wainwright, because I'm familiar with this scenario, certainly the prescription of the SSRI, because it is a psychotropic medicine, would be regarded as quite aggravating. Now, we know that Dr. Wainwright didn't, in the end, proceed from a PCC to a disciplinary charge. The sorts of mitigating factors that were able to be brought into play in his case were that the SSRI was not a medicine he commenced. He was prescribing on a repeat basis a medicine that had been started by a psychiatrist, and he did keep good notes, and his family members did have their own GPs. They only came to him on an ad hoc basis for prescribing. So taking all of those things together, what Dr. Wainwright could expect and what the conclusion of the scenario was a pretty severe telling off, not a disciplinary charge, but some ongoing monitoring of his prescribing. So in cases like Dr. Wainwright's, they will go back in 6 months' time, 12 months' time, 18 months' time, get the ministry's data again and have another look to make sure that the lesson's been learned.
Thanks, Adam. So you mentioned before that there are some situations where we can treat those close to us. So what are those situations?
So they're described in the statement as exceptional circumstances, and they are in an urgent situation where you may be required to provide treatment to yourself or those close to you until another doctor is available, or if you're working in a community where there are people close to you who have to be patients because it's difficult for them to access care from other practitioners. The statement does say, though, that even in that sort of situation, you have to be aware of the potential for your objectivity to be compromised and use good professional judgment. Have a low threshold for referring patients on to an independent doctor for consultation, and also seek advice from a colleague and utilise your peer networks if you find yourself in tricky situations. So in that sort of circumstance, or in situations where there isn't a reasonable alternative and you need to provide care to yourself or those close to you, try and make sure that you approach it like you would a normal consultation. Undertake an adequate assessment of your patient's condition based on their history, clinical signs, and provide care that you believe is consistent, that you would give to someone in an ordinary professional basis to a patient who's a stranger. Make sure that you transfer or refer the patient on to another doctor in a timely way. So even if you have been confronted with a situation where you need to step in, make sure you don't allow that to drag on. Make sure you transfer the information. So if this person has a normal GP, then they'll need to know what's been prescribed or what's been done. Make sure you maintain confidentiality of the health information. In a normal, for a primary care practitioner, of course, you're in your office, you've got your secure system. If you're providing care in an emergency situation and in a home environment, you should be writing notes, but of course you need to then make sure that those hard copy notes are kept private. And involve others. So if you need to go and do this, do it, but then reach out either to the person's normal GP and have a discussion about what's happened, or have a discussion with a peer so that you're not doing this in isolation. a good sense check to see whether in fact you've achieved that degree of objectivity that the standard asks of you.
Thanks for that, Adam. I think it's, if I'm hearing anything, it is we shouldn't be treating our friends and family unless it's exceptional. And we have to have a good rationale for doing so.
And inconvenience isn't enough of a reason, because that is what so often happens, is that it's, oh, they didn't want to wait in A&E, or, oh, they didn't want to see the after-hours doctor because it's a long way. Inconvenience isn't something that the Medical Council considers urgency.
No. So thank you, Adam and Lucy, for sharing your thoughts with us today. So just to bring this together, the learning points, I think, from today's podcast is avoid treating family, friends and self, even if it's only a prescription for Panadol. It is better to pay retail for some of these medications than go through the stress of the Medical Council process. If you do have to treat someone who is close to you, remember to write good notes, to update their regular GP. And there are certain medications where you must not prescribe them. And of course, maintain confidentiality. Thank you for listening to this podcast. I hope it's been helpful for you. We look forward to catching up with you in our next podcast. If you like the Medical Protection Podcast, please subscribe and leave a review. If you would like a podcast on a specific topic, please feel free to email us on nzpodcasts@medicalprotection.org. We'll catch you next time.